I call upon Dr. Viveka sir to take us through this wonderful topic of de-escalation therapy and illuminate us about which is the optimum strategy as far as antiplatelets are concerned. And he will be giving us a lot of data. He will simplify it for us, and I'm sure you will carry on some very important messages for your day-to-day practice. Over to you, sir. Thank you for being our guardian, and thank you for being a cardiologist, not only for us, for our families also. And thank you for responding to our SOSs, not only academic always, but personal, and you know it from personal experience with me. Friends, ladies and gentlemen, welcome to CME number 904. Wow.
Well, so good evening, friends. So at the outset, I would like to thank Dr. Chauhan and all of you for being here. And if you know that there is always a tug of war between clot and bleeding, so we need to balance the things together as far as the thrombotic diseases are concerned. So acute coronary syndrome, coronary artery disease, and all of them is something which is very, very important. So let's look into the de-escalation of antiplatelet therapy. So why do we need to de-escalate after all? So the reason being that there has been guidelines for many years, I would say for decades, that if the person has got an acute coronary syndrome or the patient has an intervention, we need to give them 2 antiplatelets and for 1 year at least, and then bring down to single antiplatelet. And there has been data that in between, when the guidelines came, we had only precursor of clopidogrel, that is diclofenac and aspirin, and that guideline stuck to clopidogrel and aspirin. And then we had P2Y12 receptor antagonists like ticagrelor, and then the strong molecule like prasugrel came, but the guideline remained the same. So it means that there is something wrong about the dual antiplatelet sanctity. And when we come down to single antiplatelet, the reason being that there are a lot of patients who would have dual antiplatelet related bleeding, so cerebral bleed and the GI bleed, the most important of the lot. There are a lot of patients who would be coming, and especially in our country where the peptic ulcer and GI problems are more common, they will have the problem. So, but on the other hand, we need to be strong enough with antiplatelet therapy so that the clot does not form. So repeat intervention, repeat clot in the stent or the bypass graft should not happen. So the longevity of the procedure has to be really, really good. So we need to have a balance with an antiplatelet which does not cause more thrombotic risk, and at the same time we should have a molecule which should not induce uncontrollable bleeding, so the bleeding complications should be there. So let's look at our common garden variety patient which we see day in and out. This is a 70-year-old female who was hypertensive, presented with STEMI, that was inferior MI, and then needed 2 drug-eluting stent in right coronary artery because she was hypertensive. So there was a long lesion and delayed. So what is the recommendation regarding the dual antiplatelet, which agent and what duration? This is what the whole crux of today's meeting is, and what would be the best strategy for the patient. So if you look at the data, there is as Dr. Chauhan had elucidated, a term called HBR. HBR is the patient who are high bleeding risk. So mainly there are patients where we can decrease the thrombotic risk, meaning thereby the repeat stent thrombosis or myocardial infarction in other arteries, but we can induce the increased bleeding complications. So who are these patients who would have? So if we have got 1 major criteria and 2 minor criteria, this is the patient who will be on the increased bleeding risk HBR group patients. So patients who are elderly, 75 plus, those who have got renal artery disease, liver disease, active cancer, patient who are anemic, patient who have got a low platelet count, stroke, bleeding diastasis, patient have got prior bleeding or transfusion, oral anticoagulants, patient who have been repeatedly taking NSAIDs and steroids, especially the patient who have got arthritis, and patient who are planned for surgery on dual antiplatelet and have a recent trauma of surgery. So these are the patients who are have to be looked at specifically. So India is undergoing a rapid transition, not only in the field of other innovations and the infrastructure, but also in the medical field. So the quality of stent has got better. So probably you see the stent strut thickness, the polymer thickness, absorbable polymer, and then these are the things where the stent safety has become much more better. So in PCI era, first generation drug-eluting stent, which was Cypher and Taxus, now we are in an era of Zyme Sierra, and we are in the Synergy, and ultra thin struts in Indian stents are also there. We have got almost 50 micron struts like the Onyx and also on. So mainly there is a thinner the strut, low the polymer, the risk of stent thrombosis is significantly lesser. So there are shifts in the guidelines as well. So if you look at the guidelines, they have come up that antiplatelet strategies to reduce the bleeding risk in first 12 months after acute coronary syndrome. Because why there is 12 months is so sacrosanct is that there are a lot of repeat events happen within a year. So now we are looking at the single antiplatelet after 3 months. So we have the single antiplatelet therapies and the data from Twilight trials and all with ticagrelor plus aspirin, and then after 3 months you don't give anything. Now we have got FDA approved and DCGI approval with the stents like Onyx, Biofreedom and all, where after 1 month you don't need dual antiplatelet. So single antiplatelet would be good now. So if you look at the guidelines 2021, SCCHA and SKY guideline, which also said that at least 6 months of dual antiplatelet aspirin and clopidogrel has to be given, and that was class 1 recommendation. And then if you want to continue, single antiplatelet after 1 to 3 months, that is 2A, and if that is where the good quality stent of bigger artery size or not very long stents is something where we need to look at that. So aspirin monotherapy after 3 months of dual DAPT is class 2B recommendations, and more than 6 months of DAPT means giving 2 antiplatelets after 6 months is 2B now. So you can imagine that it is not something which is ideally desirable, that we should be continuing to come. There was an era where 2 antiplatelets was mandatory in chronic coronary syndrome, and these patients after 6 months we should not be giving dual antiplatelet therapy. But when it comes to the acute coronary syndrome, the guideline still says that at least 12 months of dual antiplatelet has to be given, and that is class 1 recommendation. But after 3 months, if you want to de-escalate, then that is a class 2A recommendations, and that's fairly decent, because these patients who are having high bleeding risk and all, we can decrease the DAPT duration to 3 months, or those who are at extremely high risk of bleeding, we can decrease it to 1 month. And aspirin monotherapy after 6 months of DAPT. And giving more than 12 months of DAPT is a class 2B recommendation. So meaning thereby those patients who have got very long stents, multiple stents, diabetic, small vessel, high risk of repeated acute coronary syndrome, stenosis and all, so on and so forth. These are the patients where we can extend the dual antiplatelet beyond 12 months. So if you look at the JCS guideline 2020, that also used update on dual antiplatelet, and these Japanese guidelines, there they have, in India and world over, people are using prasugrel 10 milligram. The Japanese trial showed that 2.5 milligram once a day is also good enough, and there they have been using 2.5 milligram of prasugrel. The Japanese data also showed that we don't really need such a strong DAPT for long. So 75 milligram clopidogrel or 3.75 milligram of prasugrel. So you can imagine this is something which you will say that it's a homeopathic dose, but definitely it works in Asians because we have got a smaller frame. So short duration of dual antiplatelet, that is 3 main driving factors, as we have discussed again, is that advancements in the stents design. So we have got stents which are so thin that and the scaffolding across the artery is very good. So really, we don't really need the dual antiplatelets for long because the thrombotic risk is significantly lesser. And then we need to see the several studies and meta-analysis have demonstrated the benefit. So we need to balance the risk between thrombotic risk and the bleeding risk. And when we look at this, definitely these are the patients where the bleeding risk outweighs the benefit of preventing the thrombotic risk. So we need to be really, giving. So you need a very strong anti-thrombotic and anti-platelet activity during first 6 weeks, and then the things becomes better in the sterilization and all those things become the starts, and then you don't really need to be very aggressive because the downside of DAPT is that there will be increased risk of bleeding. And then again, the more awareness of the high bleeding risk population. In fact, in one of the patients who was, because in India, the dual antiplatelet becomes so cheap compared to the single antiplatelet. When you combine aspirin as per the law of the land, it becomes cheaper. So people keep on taking dual antiplatelet for lifelong, and some of them would have, understandably, cerebral bleed or GI bleed. So then they start looking at the recommendation literature and had come back and said that, doctor, you had given me single antiplatelet, but my organization gave me, the doctor said that you continue with dual antiplatelet equals to gold and so on and so forth. Then I had a bleeding in the brain. So mainly you need to look at that we should not have a devastating complication of bleeding. So if you look at the data, trials of P2Y12 inhibitor monotherapy versus aspirin monotherapy, there is the aspirin has not done as well as the P2Y12 monotherapy. So definitely when we are thinking about the monotherapy in first year, then definitely the aspirin would not be the real good answer. So short DAPT versus standard dual antiplatelet, if you see the data in acute coronary syndrome undergoing primary, PCI therapy. So short DAPT is favorable especially in patients who have got, if you look at the complication risk, especially any bleeding, major bleeding in short DAPT is significantly lesser, whereas stent thrombosis does not get affected much. Obviously, you cannot be zero antiplatelet, but one antiplatelet is good now, and if you look at the MACE rate, all cause death and everything becomes better and more favorable with single antiplatelet after de-escalation, and that's why there is so much of hue and cry about the de-escalation of DAPT to single antiplatelet. So meta-analysis suggests that in comparison with 12-month DAPT, short-term DAPT with P2Y12 inhibitor, which is clopidogrel or ticagrelor or prasugrel, reduces the major bleeding. So one determinant which is very, very important in this direction is the risk of bleeding with DAPT, which is significantly lesser with monotherapy, and that is why the emphasis is that we should be trying to decrease the DAPT as soon as possible, but we should not be trade-off of increased stent thrombosis. So what is the sweet spot or sweet point where we can go from DAPT to single antiplatelet? At least after 1 month, if you have these stents like Biofreedom or Onyx, which has been FDA approved, or 3 months with any other drug-eluting stents. So early shift from DAPT to clopidogrel monotherapy has been shown to have decreased risk of event, and also the stopping the aspirin after 1 month reduces the risk of adverse event by whopping 38%. You can imagine that we are doing so much of service to the patient if we withdraw aspirin after 3 months and make them monotherapy. One of the reasons why clopidogrel is a winner is that it does not cause significant GI side effects, the peptic ulcer and all, and the other thing is that it's a long-acting drug. So even if the patient misses a dose or two, it doesn't cause much problems, so stent thrombosis would not be really very high. So if you dig out the data from the very old trial, which is called PCI cure, cardiovascular death or myocardial infarction, that has clearly shown that the patient who have been on clopidogrel, irrespective of any intervention, if they had any acute coronary syndrome, there the clopidogrel, when you compare to the placebo, has decreased the cumulative hazard ratio, so meaning thereby that the event rates of acute myocardial infarction, hospitalization and even the death becomes significantly lesser. So Patients with acute coronary syndrome receiving aspirin, a strategy of clopidogrel pre-treatment followed by long-term therapy is beneficial in reducing the major cardiovascular event compared to the placebo. And we have the data from Charisma trial also. This is specifically for the Indian and Asian population. So Charisma did show that patients who are at a risk of moderate or severe bleeding, the Asian population had the lowest incidence of cardiovascular mortality, but a higher rate of bleeding even compared with the other ethnic cohorts. So if you compare the Caucasians versus Asians, in Asians the bleeding risk was significantly high. So obviously all the more reasons that in our country and other parts of Asia, we should try and decrease the DAPT to monotherapy so that the risk of bleeding becomes significantly lesser. And we have seen already that there is 38% risk reduction in bleeding complications. So what did the trial in the ACS data showed us? That primary efficacy endpoint to 30 months in patients who are less than 75 years, because presumably the risk of bleeding is much more higher in patients who are older, more than 75 years. So here also the trial in the data showed that among the patients with unstable angina or mitral infarction without ST elevation mitral infarction, prasugrel did not significantly reduce the frequency of primary endpoint as compared to clopidogrel, and similar risk of bleeding was observed. So meaning thereby that just escalating the antiplatelet therapy is not the answer. That is what the Twilight ACS trial also did show. So this is a AI trial with the ticket lot, and that showed that if we de-escalate the treatment Twilight, among the patients with unstable angina and mitral infarction without ST elevation MI, prasugrel did not significantly reduce the frequency of primary endpoints. It means that if you are giving the strongest antiplatelet, then also it's not doing good. In fact, the risk of bleeding outweighs the benefit. So that is what we always talk about, the risk-benefit ratio. The master DAPT trial also did show the similar thing, that if you have abbreviated the DAPT, so you can see the intent, the risk or the hazards become significantly lesser compared to the standard DAPT. So almost significant decrease in bleeding, and number needed to be treated was only 35 patients. So it means that if you are decreasing the DAPT to monotherapy, you are doing more service to your patients. But of course, we are not talking about very complex subset of patients who have had an intervention. So effect of 1 month DAPT followed by clopidogrel, we start 2 data that also clearly showed that these are the patients where the risk of complications was significantly lesser after stopping the DAPT. Host exam trial that also did show that if you are making a DAPT to single antiplatelet, the aspirin arm did not do as well as the clopidogrel arm. There was significant risk difference between the two. So meaning thereby that the thrombotic risk will be significantly lesser if you are giving clopidogrel, but the bleeding risk will be almost similar. So it means that it is a clear winner. And duration of extended follow-up was about 5 years after randomization of these patients. So it means that when we are changing to single antiplatelet in these group of patients, we should try and use clopidogrel even in patients who are at a high risk of thrombotic event when we are changing to single antiplatelet. So no favor net outcome for long-term DAPT after complex PCI patients with HBR. So patients who are elderly, had previous, those who are on chronic kidney disease, those patients who are having taking NSAIDs and all, where the risk of bleeding is high. So if you look at the non-complex PCI HBR group, complex PCI HBR group, in all these patients, the patients who are at high bleeding risk, the single antiplatelet de-escalation will be a much better choice. So individualization of the duration of the DAPT in patient with an acute myocardial infarction, those patients, we need to make choices based on the patient subset. So less than 12-month DAPT versus more than 12 months of DAPT are the patient's factor is very important. So we can de-escalate in patients who have got a prior history of bleeding, prior high risk of bleeding, are the patients where we should try and de-escalate rather than waiting for one bleeding to happen, because the data suggests that if the patient bleeds, then the risk of mortality significantly goes high. And then also there is a data which suggests that if you end up giving blood transfusions to the patient, the mortality is significantly higher compared to those patients who did not need blood transfusion. So bleeding in coronary artery disease is not a good thing to have. But on the other hand, there are certain subset of patients who would benefit from more than 12 months of dual antiplatelets. So those are the patients who are diabetic. Bad diabetics means you need to give more long DAPT, patients who have got chronic kidney disease, patients who have got heart failure, low ejection fraction, and patients with prior mitral infarction. And one of the biggest predictive value of peripheral vascular disease is there. So the patient who has got, because peripheral vascular disease are the patients who are subsets of very malignant atherosclerotic patients. When we look at the anatomical factors, so how many stents we have implanted, so that is why number of stents is directly proportional to adverse outcome. So if we have got a smaller stent, single vessel stent, then we can very easily de-escalate the DAPT. But those patients who have multiple stents, small vessel, less than 2.5 millimeter, those who have got long lesion, complex anatomy, left main coronary intervention, then those are the patients who would qualify for longer than 12 months of dual antiplatelet. And then stent related factors, so those patients who had a recent, what we call contemporary drug-eluting stents, there the risk of DAPT, you can easily de-escalate after 3 months. But those who are having, first generation long stents, multiple stents, then we need to give it for more than 2 months, to more than a year. So de-escalation is the name of the game, and that is what the whole story is there. That expert consensus recommendation on switching de-escalation is that overall registry data indicates that prevalence of in-hospital de-escalation ranges from 5 to 14%. So we automatically decrease the DAPT to single antiplatelet in hospital if the patient had, GI bleed or anything like that, or hematuria and all. Reduce the cost. So it's not only the DAPT would decrease the risk of bleeding, but will also decrease the burden of the pocket of the patient as well. Non-bleeding side effects such as dyspnea also represent a potential reason for interrupting the very good drug called ticagrelor. And these studies have consistently shown an increase in platelet activity, reactivity, so binding properties, and offset the importance of defining how to switch. So mainly we need to, when we are switching, we need to reload the patients with the newer molecule which you are going. So if you are switching from ticagrelor to clopidogrel, you need to reload with the clopidogrel again. You don't, start with maintenance therapy, just one tablet. There are a lot of patients who would have stent thrombosis. So switching and de-escalation, if the patient has taken, dual antiplatelet with ticagrelor or prasugrel up to 1 month, when you are going to clopidogrel, you might as well load it with clopidogrel, make a drug level in the body, and then go to once a day therapy. As you know, the clopidogrel has got a dose of 75 milligram once a day. So switching between the oral P2 Y12 millimeters, very early phase, you need to reload with when you are switching from ticagrelor to prasugrel or to clopidogrel, you need to be loading the patient full dose. And a lot of people fear that probably if the patient has already taken full loading dose of clopidogrel, and if you want to change it to something else, then if you load with the full dose of the next drug, will there be increase of the risk of bleeding? The answer is no, it will not happen, because whatever the platelet inhibition would be there will be not more than 90% or so. So the risk of bleeding will not be significantly higher. So very late phase also you can load in the similar manner. And then the P2 Y12 inhibitor monotherapy, after 1 month to 3 months, DAPT was associated with similar rates of fatal and ischemic event and lower risk of major bleeding. So the whole data got favored in the direction of the single or de-escalation therapy because of the offset done by the bleeding, increased bleeding rate. So what does the guideline say? The latest BSc 2023 guideline also suggests that clopidogrel monotherapy is superior to continued dual antiplatelet for an individual. Additional 9-month reductions were noted in both ischemic and bleeding events. So it means that it does not increase the ischemic risk. At the same time, the bleeding risk also goes down. So definitely this is a blessing for these patients. And also extended clopidogrel monotherapy versus dual antiplatelet therapy is also, so BRISC trial also has shown that there is no added advantage of giving long term beyond 1 year also the DAPT, the clopidogrel therapy versus do it DAPT, because the DAPT would induce more bleeding without adding any significant benefit on this single therapy of clopidogrel in these group of patients. Switching from ticagrelor to clopidogrel in Asian patients with respiratory elevation mitral function, this is again a data which has shown that when you switch, you need to fully load the patients. So compared to ticagrelor only group, the switch group patients were not significantly associated with Cmes or the other cardiovascular adverse events. So if the patient have got unbearable side effects with ticagrelor like breathing difficulty and is not able to tolerate, then we should switch to this. And we have seen that many times those patients who have been having significant bleeding complications with ticagrelor, when we switch them to clopidogrel, the risk of bleeding goes down significantly, and at the same time, the safety of stent thrombosis and all is also taken care of. So it's not something where it is harmful. Again, we have data from India also, which is again illustrated the same thing. If you see the impact of bleeding risk in modulating the dual antiplatelet therapy, it is again the 42% of the cardiologists rated bleeding as risk in few patients, 41% indicated that they considered shortening the duration of DAPT due to bleeding concerns in few patients, and 61% strongly believe that balancing between bleeding and ischemic risk influences the choice of antiplatelet agent when treating the established coronary artery disease. So meaning thereby that we need to give a patient therapy which is beneficial to the patient and decrease the risk of complication, and that is why the buy-in for clopidogrel in patients after acute phase is over, maybe 1 to 3 months time, it is better, they will be better served with the antiplatelet like clopidogrel to decrease the bleeding risk, but to keep the antithrombotic risk at bay. So perfect de-escalation time. So when should you start trying to do that? Most of these stents, they become stable, patient becomes better, and then 3 months is the time where we can de-escalate to single antiplatelet, though it has not yet come in the guidelines. Guidelines still say that 6 months would be the ideal time, but now with the current practice trend, we see that the 3 months is the time where after that you can shift from ticagrelor or prasugrel to aspirin and clopidogrel. And if you want to give the single antiplatelet, clopidogrel would be good enough, single antiplatelet. So what is the top line findings of this whole data is that studies indicated that the majority of the coronary artery disease patients receive DAPT immediately after intervention. Perfect de-escalation time frame for Indians coronary artery disease patients with high bleeding risk is up to 3 months, 6 to 12 months for medium bleeding risk, and more than 12 months for low bleeding risk. So obviously those who have the least risk of bleeding, then we might as well continue for 12 months. Otherwise, we should follow this dictum. 1/3 of the respondents used clopidogrel as an antiplatelet agent in 50 to 75% of single antiplatelet eligible patients. So when we are going to, the more the time from the intervention, the safer is clopidogrel because of the above reasons. And when you need to give all your patients statins plus clopidogrel, so might as well combine atorvastatin and clopidogrel. That will be predominantly the most preferred combination of statins plus single antiplatelet, and need for Indian specific guideline for de-escalating the DAPT to single antiplatelet is something which is the need of the hour. And I think these data clearly suggest that because a lot of Asians and Indians were part of this trial, so I think that would be the answer, that we de-escalate to clopidogrel and then be happy with decreased bleeding risk and improve long-term outcome in these group of patients. So thank you very much for your kind attention. If there is any question, I will be more than happy to answer that.
Dr. Kapoor sir, don't leave. There is a gift for every guest sir, and if you leave, there is no gift sir. I'm sorry. There is no home delivery sir. There is no home delivery. So I would request you to please for a change your strategy and stay here for some time. We had a wonderful presentation. Big hand for Dr. Viveka sir. Before I come to my learned audience, I would like to ask a few questions to sir. Sir, you mentioned about a consensus now for a shortened DAPT and then followed by SAPT. I have seen many of your prescriptions after ACS where you are using ticagrelor, 90 milligram twice a day, and along with aspirin, sir. And when the patients have some problems associated with ticagrelor, especially the dyspnea part, I see you changing it to prasugrel. I understand in the general population, 3 to 6 months. What about the diabetic population? It's a population which is vulnerable to more ischemic events than the standard population. So your take on that?
Yeah, so I think that's a very good observation. So if you look at the first 3 months, especially if we need to switch, then we try and, because ticagrelor, almost the data says that 8% of people would have breathing difficulty. In our country, there are a lot of people who have COPD and pollution-related issues. So we are forced to change them to, prasugrel. But for first 3 months, we try and continue because the clopidogrel resistance is there in almost 25-30% of Indians. So we don't try and give it in early phase of intervention because stent thrombosis is much worse than acute myocardial infarction. The mortality is in a stent thrombosis is almost 2 times than the acute myocardial infarction, which is in de novo patient. So that is the reason why we try and give reported antiplatelet P2Y12 receptor antagonists like ticagrelor. If they are not tolerating, then second choice is prasugrel. But after 3 months, the bleeding risk outweighs the thrombotic risk because things are stable in a stable position by that time. So we try and give them clopidogrel and then we try and continue that. And if you look at the guidelines, patients who are at a very high bleeding risk, after 3 months you switch to clopidogrel. Patients who have got moderate bleeding risk, you can go up to 6 months DAPT, and patients who have got low bleeding risk, then might as well continue for 12 months.
Sir, I also wanted to ask you regarding your strategy after you have done or dealt with an intervention in acute coronary syndrome. Before you had this presentation, sir, what was your strategy? For how long were you using dual antiplatelet as a standard of care? And then how many months after you were coming to single anti? I have not seen many of your, please excuse me for that, many of your prescriptions where you have used single antiplatelet. You either go to prasugrel and aspirin or you go to aspirin and clopidogrel. Are you going to change your prescription habits in the light of this consensus statement, sir?
Yes, I think those patients who are on the more than 6 months, so we have changed to now definitely we are changing in this direction. So of late, in last 1 year, this data, because look, one of the things which is there in current contemporary medicine is that whatever you do right or practice, you need to be supported with the data. So if the data and the guidelines do not suggest that and something goes wrong with the patient, obviously you cannot defend yourself. So once it has come in the guidelines, you are right that now they are brave enough to follow this treatment. But till that time we were following, as I said, DAPT for at least 6 months to 1 year. So after 1 year, definitely our 90% of the patients are now on clopidogrel and statin, not aspirin. But those who cannot afford clopidogrel, obviously we go with aspirin because that's a cheaper drug.
Sir, my last question before I give it to the audience. There has been criticism of clopidogrel regarding its very nature of pharmacokinetics, pharmacodynamics. It's a irreversible P2Y12 inhibitor as compared to the newer antiplatelets like prasugrel and ticagrelor, which are reversible P2Y12 binders. So, and there is a problem of the variability of effect of clopidogrel in the past. Many studies have demonstrated that there is a population which has clopidogrel resistance, and it can vary from 2% to 90%. So if we come to single antiplatelet as our main focus, as you mentioned about a combination of atorvastatin and clopidogrel, do we do any test to find out whether the person is clopidogrel resistant or not?
Yeah, so that's a very good question. So, it has been seen that the matter of resistance of clopidogrel matters in first 3 months. So that is why you will not see too many prescriptions that in 3 months we are including that. And in acute cardiac syndrome, primary PCI or post PCI, that issue was there. And if you look at the Indian patients, almost 25 to 30% of them were, clopidogrel resistant. At one point in time, we were celebrating that we have got other molecules than clopidogrel, we have ticagrelor and prasugrel. So, but surprisingly, after 3 months, it doesn't matter whether the patient is clopidogrel resistant, because after 3 months, you don't need that percentage of platelet inhibition. So platelet inhibition, so when the patients have got variable clopidogrel resistance, platelet inhibition comes down from 55-60% to 30%, but that 30% platelet inhibition is also good enough for maintenance therapy, and that's the reason why the clopidogrel becomes winner. When you compare with the single aspirin therapy, the platelet inhibition is not that high. So probably the issue of resistance with clopidogrel matters only in first 6 weeks, I would say, and then it weans off. And then you have to give a antiplatelet which has got long action. Probably the irreversible nature of the clopidogrel also plays a role. The long duration of action also plays a role. And then the side effect profile is lesser. So the GI side effect and all is lesser. The patient tolerate it much better. So probably that is why the data after data, DAPT data, and all of them have shown that the clopidogrel monotherapy is safer than any other antiplatelet therapy after 3 months.
So the dose of clopidogrel in single antiplatelet therapy, 75 once a day, or 75 twice a day, or 150 milligram once a day?
75 milligram once a day.
And we can combine it with atorvastatin?
Yes.
Sir, what is the dose of atorvastatin if I give dual antiplatelet for 3 months, and if I follow it up with single antiplatelet along with atorvastatin? Do you keep the dose of atorvastatin on a higher level?
Higher level. So basically, the atorvastatin 80 milligram up to 1 year is standard. Though in the combination therapy, they have maximum up to 40 milligrams. So, but still, you can add another 40 milligrams.
So I want to ask Mr. Chandan, do you have a combination of 80 milligram of atorvastatin with clopidogrel 75 milligram?
No, sir. Currently we have 40 with 70. Plain atrophic 48 is available.
So sir is saying that they will need to continue at least for a longer duration with 80 milligram.
I have taken that point. I will discuss it.
Yeah, sir, my last question, my very last question. When you use a single antiplatelet, of all the antiplatelets that you have been using, which is the commonest bleeding risk? Is it the intracranial or the GI?
So the commonest is the subcutaneous bleed, ecalmosis, and then the second common is the GI bleed, and third is the intracranial. So intracranial happens most commonly during the intervention phase. So when you are putting the stent, because you are giving heparin also, so the ACT is high, so that's the time where the maximum risk is there. Nonetheless, the intracranial bleeding risk is there, same as in after 3 months, it will be same after 1 year, same after 3 years. So the problem is that the intracranial bleeding happens, massively if the patient is on prasugrel or ticagrelor compared to clopidogrel, but it does happen.
Dr. Tulsi sir.
So,
You are audible, sir. You are audible.
yeah. So, once again, a wonderful talk by our esteemed Dr. Viveka. So, Dr. Viveka, you presented various trials on DAPT versus SAPT. So, some recent findings presented at the ACC 24 in Atlanta on the ultimate DAPT trial. Also on the ACC CSI presented in August. I think you were there at Pullman. I was there. So guidelines currently recommend DAPT, aspirin plus potent P2Y2 inhibitors for 12 months in most patients presenting with an ACS to prevent MI and stent thrombosis. So the aim of this trial, the latest trial, the ultimate DAPT trial, this was to assess whether the use of ticagrelor alone as compared to tica with aspirin after 1 month of DAPT could reduce bleeding without increase in MACE. So the findings was that, you see, indeed, if you give a single platelet or SAPT like ticagrelor, the bleeding is much less, and the MACE is almost comparable if you give tica alone or with DAPT. So the large-scale multinational trial, but sadly 97% of the people were Chinese or Pakistanis. So very few Indians were involved here. But as we know, we are all Southeast Asian. So would you say, Dr. Viveka, that Southeast Asians people tend to bleed more than the Caucasians?
Yes, I think that's very important point. So South Asians and Asians in particular, they have a high bleeding risk because of this not fit body size, and also concomitant other issues like more GI diseases than the other. First, always more into very spicy food and all those things. So if you look at the peptic ulcer and all, it's significantly higher. So ticagrelor therapy is something which is going to be monotherapy from it. So if you look at the recent Lancet paper, there it has written that as the time comes to write an opportunity for aspirin. So that's the status of aspirin, because now the monotherapy ticagrelor trials for intervention is undergoing, and we have a positive interim data. So probably we don't really need aspirin now on. And but again, if you look at the comparison between ticagrelor versus clopidogrel for long term beyond 3 months or 6 months, the bleeding risk with ticagrelor is again higher compared to clopidogrel, but the risk production from the thrombotic risk is same. So meaning thereby that up to upfront 3 months you need to give ticagrelor, or at least for 6 months in patients who are of moderate risk, and then you might as well shift to monotherapy of clopidogrel. That will be the answer in future, I would say.
So Dr. Viveka, such an astute cardiologist like you would always prefer ticagrelor versus clopidogrel or prasugrel? Dr. NK says yes. So most of the cardiologists today prefer ticagrelor instead of clopi, because we know resistance is there, especially if the ischemic risk is very high. But if the bleeding risk is high, probably you would not, probably not go for ticagrelor and probably go for clopidogrel. So would you say the ischemic risk and the bleeding risk would determine what you choose?
Absolutely. So we have got what we call bleeding risk calculators, the HBR risk which I have shown, and then there is a bleeding risk calculator also. So you need to have a balanced opinion. So those who have got high bleeding risk, you give them slightly more thrombotic risk of protection, and those who are at a high thrombotic risk we need to compare. But there are certain group of patients who have got they are high bleeding risk also, and they are high thrombotic risk also. But the mortality is much higher if they bleed compared to they get thrombosis.
Absolutely. So that's great. So circulation July 2024 demystified the role of 12-month DAPT. Like to ask Dr. Viveka, how do you demystify the role of 12 months DAPT? After ACS with both ACC and the ESC has been advocating for decades, for at least 2 decades, and they said that probably, we know DAPT has a class 1 indication, and SAPT still hasn't a class 1 indication. Your words on that?
Yes, I think the the guidelines which have been there, sacrosanct for so more than a decade,
Yeah.
then it takes time. So you need to have a really good hard evidence based on the trials, and then because when you make guidelines, you cannot make it based on the expert opinion consensus. You have to have data, and that's the reason why people did not have the courage to do a trial without aspirin from day one. Now we have the data, it's coming up. So once it gets published, I would say that the story of aspirin will go away.
So, Dr. Chauhan, read a little on de-escalation, multiple DAPT de-escalation strategies, like, switching from Prasu to Tika to Cloppy and reducing the dose of Tika and Prasu and shortening the duration of the DAPT, while maintaining the monotherapy with ticagrelor, which has constantly shown to reduce bleeding without increasing Cmes. So, however, the 12th one DAPT still remains the class 1 indication today. What do you say, sir?
Yes, so I think, so all we have discussed about so when you need more antithrombotic, we need to choose the newer antiplatelets like the ticagrelor and prasugrel. We have been using now injectable cangrelor also in acute phase when we are taking for primary PCI and those patients who are naive patients, we inject cangrelor, and also in patients who are as a bridge therapy cangrelor is being given. Now prasugrel is something which is it's a very potent and long-acting antiplatelet. So when the patient is committed for primary PCI, then only we can give. So once we have done the angiogram, patient is already committed for primary PCI, and there are a lot of contraindications. If there is no contraindication, like if the age is not 75 plus, if the patient's body weight is more than 60, so those are the inclusion things when we need to take it. And then so now we need the data, and the good thing is that the stents have evolved in such a way that we have got a thin strut stents where the risk of stent thrombosis is hardly there. So in those situations, why to take risk of bleeding? So that is why the prasugrel has gone out of favor. The reason why you said that people love ticagrelor is that it's not only potent, but it's a short acting. And then you can de-escalate in patients who are bleeding to 16 mg twice a day rather than 90 mg. That is what we have been practicing. But it's not come in the guidelines. But if you see, there are many patients in acute phase also. We have decreased it to 60 mg twice a day, and that too as a monotherapy, because discontinuation of maximum stent thrombosis happens when you change from one drug to other drug, because the adequate blood levels are not there.
My last question, on probably a lighter note or a humoral note, would be, women historically have been underrepresented in various RCTs. So why is that? Is it that we understand women less?
Well, I will not say that.
Lighter note, sir. Thank you, sir.
So it's basically the contracted disease is
Dr. Tulsi sir, kindly give the mic to Dr. P.K. Mangla sir. We will keep Dr. Anil today till the end. It is my strategy.
Dr. Viveka, aspirin has been a drug which has been used for many, many years. Whether for CBA, for ACS. Now is it, now the dual platelets are ticagrelor and clopidogrel. Once you are giving DAPT, you are giving these two drugs and withdrawing ticagrelor and continuing with...
No sir, dual antiplatelet would be ticagrelor and aspirin, or clopidogrel and aspirin, or prasugrel and aspirin.
Yeah.
Once you come from DAPT, you have to take out aspirin and you have to put only on clopidogrel.
Yeah. So as you second one is aspirin.
So aspirin has been till now is the was the constant companion whatever your second drug was. But now we are trying to see that can we do without aspirin, because with aspirin and with the newer antiplatelet the risk of bleeding was significantly higher. So still our neurologist friend for the brain stroke and all, they don't like ticagrelor, and they have got absolute no for prasugrel, so they don't use prasugrel. So aspirin and clopidogrel for them was better because the risk of bleeding is significantly higher with ticagrelor and prasugrel. But for the cardiac event, the aspirin plus ticagrelor in acute phase, patient who is at a very high risk of thrombotic and very young patient, larger thrombus burden, where the prasugrel will be, with aspirin will be the answer. And the third thing is that when you go for the maintenance therapy beyond 3 months or 6 months, or maybe after a year, then monotherapy of clopidogrel will be good enough because it gives good thrombotic protection with less bleeding risk also.
We have been continuing aspirin with ticagrelor for 1 year.
Yeah.
What is the bleeding risk during this 1 year period? So suppose for 3 months or 6 months.
So it's not uniform, so mainly we need to choose, that is why we need to see the score of XPR score, that is those patients who are at a high bleeding risk, those patients who are at a high clotting risk. So suppose a patient who is non-diabetic, non-smoker, had a very short one stent, he would be, he doesn't deserve the dual antiplatelet to, lead into complications. So there we can de-escalate immediately after 3 months to single antiplatelet, which is clopidogrel, which has shown a lot of good data of late. But also in patients, so those patients who are very thin, they weight more than less than 60 kilograms, age more than 75 years, and elderly had uses of NSAIDs or steroid for various reasons, like your COPD patients who are on steroid. We would not like to give them the higher antiplatelet could cause GI bleed. So in those situations, we'll rather give a short ticagrelor aspirin therapy for 1 month to 3 months and then de-escalate to single antiplatelet.
And for practically all patients, after 1 year you have to withdraw.
All practical patients. So beyond 12 months, we need to again, so that is the area where the high thrombotic risk group comes. So high thrombotic risk are patients who have got chronic kidney disease, on dialysis, those who are bad diabetics, HbA1c is high. And there we have put, multiple stents, more than 3 stents is considered to be high thrombotic risk group. So in those situations, we should continue dual antiplatelet beyond 1 year also, unless the patient is high bleeding risk.
Dr. Mathur sir, and before you ask the question sir, I would like to say something about दिल sir. दिल जो है सर, आपको पता है दिल तो पागल है, दिल दीवाना है। पहली बार मिलाता है यही, सीने में फिर आग लगाता है, धीरे धीरे प्यार सिखाता है यही, हंसाता है यही रुलाता है। दिल तो पागल है, लेकिन गाने वाली बात नहीं है। अब सर सवाल पूछेंगे, क्योंकि सारी रात जगाता है यही, अखियों से नींद चुराता है। सच्चे झूठे ख्वाब दिखाता है यही, हंसाता है यही रुलाता है। दिल तो पागल है।
दिल के अलावा और भी बहुत चीजें रुलाते हैं। थैंक यू सुशील सर, thank you so much sir, Dr. Viveka sir, thank you very much for a very nice talk on dual platelets and de-escalation of platelets. Sir, my small question, we lot of patients we give a single platelet aspirin for many years they are taking it. With your talk, do we change them to clopidogrel?
Yes, so I think the data suggests that the clopidogrel will be a better molecule for 2 reasons. One is the side effect profile is lesser. The second reason is that the thrombotic protection is much better. So risk of stent thrombosis and all after, so if you look at the patients who have had a intervention, had a stent or bypass graft, it has been seen that the patient's graft patency and the stent patency rates are higher in patients who are on clopidogrel compared to those who are on aspirin, and that is why we say that now it is time to say goodbye to aspirin, our good old aspirin. And obviously the critics say that things which are cheaper, medical professionals do not like it. But the truth of the matter is that if you look at the safety profile, clopidogrel definitely outweighs the aspirin. So, old habits die hard, so that is the same case with aspirin, because we feel that, one generation of physicians have lived with aspirin that was a sacrosanct, and you cannot believe. So I can tell you a story when I was, we presented a data along with the, the American Heart Association, our data. So I was the one who presented 3,000 patient data with ticket log, and out of that 1,500 of them were on monotherapy of ticket log. And then the guidelines came that those who are on newer anticoagulants like the apixaban or rivaroxaban and all, even if they have a stent, after 1 year they don't need aspirin or any other antiplatelet. After 1 year, the NOACs, if they are taking NOACs for 80 patient to stroke prevention, they don't need on aspirin. And the data was so strong that it had come in guidelines. And Greg Store, who was considered to be, had done many trials and all, he was the president of American Heart Association, and he said that show of hands, that how many cardiologists, and all of them are elite cardiologists all across the globe, that based on this data, how many people will not give their patients aspirin who had a stent in past when they are on NOAC, and only to those people who were part of that trial, they raised their hands, and other people did not agree with that. So that is the power of your practice and regular, what you have been doing day in and out, because you believe what you do and what you see, and that's the reason why people still feel that the aspirin is. The moment we have more data in and out, so for the last couple of years we have been using treatment without aspirin, and we are very happy with that, and the patients are doing really well. So now the time has come that we don't really need aspirin. That is why there is so much of knowledge that can we write an obituary to aspirin.
Thank you, sir. Gradually we read of aspirin. Thank you, sir.
Dr. Anil Gupta, sir.
Sir, when you say that collaborative resistance, it is not absolute resistance.
No, it is a relative. So it can be easily overcome by increasing the dose.
Part of my question asked by Dr. Anil, is there any blood test or genetic test by which we determine clopidogrel resistance, and then we can avoid clopidogrel in those patients, or if there is no resistance, we can give since beginning also?
Yes, I think if there was, before the ticagrelor, became off patent, it was costly drug. So a lot of companies came with genetic testing for clopidogrel, and it was that, in cath lab we had kits to test whether the patient is resistant to clopidogrel or not. If resistant to clopidogrel, don't give clopidogrel, give ticagrelor. But as the ticagrelor came off patent, and then as Dr. Anil said that it's not an absolute resistance, so you can come over the resistance by increasing the dose. So that is what Dr. Chauhan was saying, that initially you give 75 milligrams twice a day, and instead of loading with 300 milligrams, you load with 600 milligrams of clopidogrel. So you can overcome the resistance, and resistance is never absolute resistance, it's a relative resistance, so it can be easily overcome by increasing the dose. So coming to your question, that is there any use? So all these agents which were discussed at clopidogrel resistance and whether so those kits have gone out of use because nobody is doing. It's not cost effective anymore now, because if you feel resistance, which matters initially 1 month to 3 months time, you might have give them newer antiplatelets and then shift back to clopidogrel, because the data has said that without testing the resistance of clopidogrel, 100% of the patients do better as maintenance therapy with clopidogrel than the other antiplatelets.
They know resistant to other antiplatelets? That's a very lot of
You mean there is a cross resistance? There is a cross resistance.
But it is again partial resistance, it's not an absolute resistance.
There used to be a test called Verify Now, sir, with clopidogrel. No longer being used?
No, so it is there, but it's again for research purpose and all.
Okay. The kit is not in routine use.
Not.
As you said, it is not very cost effective. Right. Any other questions?
Yes, Dr. NKG wanted to talk about the post-exam trial. And he said he observed that clopidogrel is superior to aspirin in patients of chronic
De-escalating it and also making it dual pathway. So now there is a data, if you look at the COMPASS trial, that clopidogrel, aspirin plus the 3.5 milligram of levodoxapine. So in chronic Walden's syndrome, you can give a smaller dose of each, and probably that works better than the escalating aspirin or omeprazole.
Thank you, sir.
Thank you, sir, for a wonderful presentation. I would, before I call Mr. Chandan to say his word of thanks, I would like to express my gratitude to all of you for listening to sir in great calmness and for this wonderful interaction. Dr. Jitendra, you have not asked a question for last 17 CMEs. It's not done.
So you can expect in the next CME, sir. I will come prepared like Dr. Tulsi. So maybe, I will ask no questions.
You know that famous live trial which had huge adverse benefit to cost ratio as far as aspirin was concerned, and I remember from my post-graduation days when everybody after 40 years hypertensive diabetic was on aspirin. That trial has shown with abundance that it is not a good strategy to use aspirin as a preventive strategy in those patients for reducing ischemic events, because it is offset by the bleeding risk. Therefore, be careful with that thing, and with Consumer Protection Act kicking in, you are liable for real problems.
Which one to give?
Don't give if it is not recommended. If it is not recommended, don't give. If confusion, refer the case to Dr. Viveka. The second thing is that as far as acute coronary syndrome, unstable angina is concerned, if you have used dual antiplatelet, you have referred the case for intervention to Dr. Viveka. 3 to 6 months are very crucial because there is a very high thrombotic risk and it offsets the bleeding risk. After 6 months, we are not sure. That is a time period when we have to be careful, and you must take care that the patient does not die because of a bleeding risk rather than a ischemic, because the ischemic risk reduces as the time goes by. Therefore, it is a good strategy. At least the consensus is after 1 year, definitely between 6 to 12 months, probably a grey area if the patient is a diabetic, and then you can go to single antiplatelet, and the single antiplatelet of choice is clopidogrel, not prasugrel, not ticagrelor, and not aspirin. Okay, and since now you have combinations of atorvastatin and clopidogrel available, and since you need to give both, therefore you need to give a high dose of atorvastatin and clopidogrel 75 mg once a day. You can use lot of combinations. One of the combinations available is by the company, and you know that by now. Okay.